So like each one of us in this audience, I care very deeply about my patients. Some of them really enliven me by their spirit, and others inspire me with their resilience. Allison is one such patient who really embodies both of these qualities, and for that I hold her very dear to me. This is Allison when she was 6 months old, before I knew her. She had been thriving, very healthy, enjoying her life with her parents in Vermont. And at a time at 6 months when she started taking in solid foods and she should have been gaining weight, she started to lose weight. Her parents were concerned and brought her to her pediatrician. And they worked on some strategies for weight gain, but her weight loss became alarming. She became increasingly emaciated over the next several months. And it wasn't until her pediatrician noticed a to and fro movement of her left eye that we call nystagmus that her brain tumor was discovered. And this brain tumor was the cause of her weight loss and her nystagmus. Nystagmus is a serious eye condition that, when recognized, requires referral to an ophthalmologist because it may be the harbinger of very devastating disease. So the goal in my presentation today is really to empower you to recognize nystagmus, to recognize the importance of the referral, because this referral really saved Allison's life. So let's talk a little bit about what we mean when we say nystagmus. I think just clarifying the definition of nystagmus would be important. So you've heard a little bit about it from Dr. Daghi, but nystagmus is basically a to and fro rhythmic movement of the eyes. It always starts off with a slow phase. So there's a slow movement and then a refixation movement. So the slow movement is the deviated movement, and then there's a refixation. So if the slow movement is slow, we call this pendular nystagmus. It looks like a pendulum swinging. If the slow movement is followed by a fast refixation movement, we call this jerk nystagmus. And when we try to describe nystagmus to one another, we describe it as pendular or jerk nystagmus. We also want to clarify in our minds, is it involving one eye, monocular nystagmus, or is it binocular nystagmus? Because that has important implications for underlying etiology. We want to look at the plane of the nystagmus. So is it in the horizontal plane? Is it vertical? Are the eyes sort of twisting? And we'll talk about this further, about why these characteristics may be important. So you send a child to us, and we start to look at these characteristics, and these characteristics help us to begin to understand what is the underlying etiology. So here is a form of nystagmus that we see quite commonly in our pediatric patients. You can see here that the eyes are moving side to side, so we call this horizontal nystagmus. It's binocular, so it involves both eyes. And you can see that the child, although he's looking to the right, to the left, up and down, the eyes still stay in the horizontal plane. This is probably the most common form of nystagmus that we see, and it has a number of implications and underlying etiologies. So what are these etiologies? The first thing that we look for when we see this type of nystagmus is we look for any structural abnormalities of the eye. So this type of nystagmus may be the kind of nystagmus you would see in your patient with a bilateral congenital cataract, that the eyes are moving side to side, and sometimes we may even say they're roving because they're non-purposeful movement. We see this type of nystagmus in our children who have optic nerve hypoplasia, and so it's important to refer the patients because of this. This type of nystagmus may also be the kind that we see in the inherited retinal degenerations that Dr. Al-Farashi was talking about. We see this type of nystagmus in our children with Down syndrome. And we've done a study of 800 children who had Down syndrome who presented to Children's Hospital and looked to see if that nystagmus was associated with any neurologic dysfunction. In fact, we found that none of the patients who had Down syndrome with nystagmus had underlying neurologic or neurodegenerative disease. So we don't exactly understand why it's associated with Down syndrome, but we think it's a feature associated with the disease but may not represent sort of a progressive or neurologic condition. There are families who have X-linked forms of nystagmus that are characterized by this horizontal movement. And then finally, we have kind of a catch-all that we call idiopathic nystagmus. And it used to be called congenital nystagmus or motor nystagmus, but now we call this idiopathic infantile nystagmus syndrome. So it's a lot to say, but the idea is that this form of nystagmus, when we see it, has certain implications for what we need to do next. So a child who comes to me with this horizontal, binocular, conjugate nystagmus will probably end up seeing our retina service for a possible electrophysiologic testing. They probably will also see genetics in order to see if there's an underlying genetic condition that's contributing to the nystagmus. But it's less likely that this type of nystagmus is associated with devastating neurologic disease. So let's look at what distinguished Allison's eye movement from this common form of nystagmus. So this is Allison, and here I want you to focus on her left eye. So first we were talking about, okay, is it monocular or binocular? So I would suggest to you that the only eye that's moving or bouncing is her left eye. So I would characterize this as monocular nystagmus. And as you're looking at the movements, it's kind of hard to really understand what plane is it. Sometimes the eye is moving side to side, while others it's bouncing vertically. It doesn't have necessarily kind of a uniform plane. But we do call this nystagmus because the movement starts off slow and then it sort of oscillates in a slow way. Allison's pediatrician knew that monocular nystagmus is associated with neurologic disease. And specifically, monocular nystagmus is associated with tumors of the anterior visual pathway. It's not to say that we see monocular nystagmus and we definitely know that there's going to be a diagnosis, but because of the high prevalence and association between this and tumors of the visual pathway, these children must be referred urgently, and they have to have MRI, brain, and orbits to look for a tumor. So in Allison's case, that recognition of the nystagmus brought her in immediately. She had the MRI and the tumor was discovered. So what are some other types of nystagmus that we might be more concerned about that require referral quite urgently? So if we see vertical nystagmus, so the eyes are bouncing in the vertical plane, or this nystagmus is associated with a twisting of the eyes. So this type of presentation may be associated with structural abnormalities of the brain stem, the cerebellum. For example, a Chiari malformation might present with a downbeat nystagmus. Some children with the neurodegenerative disease Pelizaeus-Merzbacher have sort of a vertical and upbeat and elliptical type of nystagmus. We also know that children who have retinal dystrophies that Dr. Al-Qurashi talked about can have vertical nystagmus, but we would put this lower on our list. So if a child comes in with vertical or torsional nystagmus, we would most likely do a neurologic workup, and then if that neurologic workup is healthy, then we would send them for electrophysiologic testing. There are some medications that may be associated with the onset of nystagmus, so it's important to do a thorough medication history. So for example, lithium and lithium toxicity may be associated with a downbeat nystagmus. Children who have, I saw a child with upbeat nystagmus who had a history of necrotizing enterocolitis and had a malabsorption kind of condition, so he presented at 5 with a Wernicke's encephalopathy and upbeat nystagmus. So it's important to look at the medical history, look at the family history, look at the medications, and refer. Now that we know what nystagmus is, let's look at what it may not be. So here we see, okay, it's binocular, the movements are together, but I would argue to you that these movements are multiplanar and they're fast. There isn't a sort of initial slow phase. The eyes are moving around, they're moving side to side, they're moving up and down, and he can't stop it. This is a very important distinction from nystagmus. So this condition we call opsoclonus. And opsoclonus is different from nystagmus insofar as the eye movements don't have that initial slow phase. Opsoclonus has this multiplanar property. And importantly, opsoclonus is associated with neuroblastoma. It's a paraneoplastic manifestation of neuroblastoma. So if you see this type of kind of strange, almost fast forward, we call it saccadamania, dancing eyes. If you see these characteristics, This patient should also be sent in urgently, but for a different reason. He would have a workup for neuroblastoma. So what happens when a patient comes to us? We've alluded to the fact that nystagmus has to be seen urgently, but when a patient comes to our clinic, I think the first thing that I do with my patients is really discuss what is the underlying etiology. And that helps me to stratify. Do I need to sort of send for genetics or retina? Do I need to send neuroimaging? Do we need to get neurology involved? And then we have a discussion about visual prognosis, because nystagmus in and of itself cannot be cured. And some forms of nystagmus are associated with good visual outcome. So that idiopathic infantile nystagmus syndrome, many of these children will end up with actually quite good functional vision, even close to 20/20 vision, while others who have inherited retinal degenerations may become legally blind. In Allison's case, this is Allison 5.5 years later, her nystagmus really was a reflection of profound visual impairment. And in her left eye, she went blind completely. However, you can see her. This is 5.5 years. She's been coming to me approximately every 3 months for the last 6 years. And after multiple craniotomies and multiple rounds of chemotherapy, she's thriving. She's doing well. She's playing tennis, and I love that she plays violin, as everybody knows how much I love violin. And she's skiing, and she's really enjoying her life with her new baby sister and her family. So if there's something that I'd like to leave you with, an impression that I'd like to leave upon you, is that nystagmus must be referred. It's an important and serious diagnosis. It's not part of normal visual development. And I want to empower you so that now you'll be the next person to save a child like Allison. Thank you.